Thank you for inviting me to talk in this meeting. I have no disclosures, but I have two confessions. The first one is that I actually have two fathers, my dad, Galal El Said, and my dad, Chuck Mullins. The other one is that I'm going to be using Dr. Mullins' book to show a lot of the diagrams that will help us along this talk. So I'm going to focus on femoral axis, particularly arterial axis. There are multiple complications from arterial axis, bleeding, hematoma, retroperitoneal bleed, thrombosis, vessel tear, pseudoaneurysm, AV fistula, and leg discrepancy. We are going to focus on thrombosis in this talk, and thrombosis can lead to ischemia of the foot and also can lead to leg discrepancy, which is very disheartening for me. So prevention is the best treatment. Don't access the artery just because you can. Chuck said avoid it at all costs. Use a quick cath initially and then exchange to the sheath, and delay putting the sheath until the end of the procedure. Start with a quick cath. If you have to go to war, go prepared. So know your grounds. So know your anatomy really well. Both know that the vessels dive down when they get into the retroperitoneal space, and so you're not going to be able to hold pressure very well there. So you don't want to perk too high above the inguinal ligament, or too low where the vessel dives down, or perpendicular where you can injure the back of the vessel, but you want to perf perfectly below the inguinal ligament and at an angle. So know your weapons. So don't use a large bore needle because, as you can see, it'll perforate the back of the vessel. And you want to avoid the through and through puncture because the back of the vessel will also be injured. You want to use a wire that allows you to go in and have a feel for what's happening distally rather than kink as it goes in. Your bevel has to be up, and you don't want to use a J-wire because it will hinder you entering the vessel. It is very important to have a good taper between and a lack of mismatch, because if you have mismatch, you will create an injury. You want to drill on your way in to avoid the lipping that you can see at the top of the screen, and by drilling, you can get into the vessel with less injury. You want to position the legs. Don't do this. The frog position doesn't work very well. You can always perforate the vessel, but you can't access it afterwards with a wire. You want to elevate the groin, put the legs in a, turn the knees straight up, put a tape on, and put your feet in the pigeon toe position. And this is your final position, and you're ready to perk. So prepare your weapons. So you want to use a wire. The one I prefer is the micropuncture wire because it has a very soft end, and then after that it gets relatively stiff, so it gives you maneuverability in the vessel. You want to use a needle that's got a small bevel like the AMC needle, and you want to use a non-luer lock syringe so you don't manipulate too much. Flushing with heparinized saline, which I see that when lines are placed in the PICU, they flush with normal saline. And this is, take advantage of the technology that's coming out. So there's small sheaths, like the Mongoose sheath that's 3 French, and that helps. The smaller the sheath, the better. So now you're ready. You're going to start to perk. So you need to feel your landmarks, and you need to know where you're going, and go with the needle alone. Don't go with the syringe with the needle, because that you tend to be more aggressive when you're doing that and not have a good feel for where you're going. Once you're in, you're going to thread your wire, and you're going to check your wire position under fluoroscopy. You could use a butterfly if you need to in smaller children. Now use ultrasound. You don't have to go blind anymore, but you have to be careful with ultrasound. So this is using ultrasound. You can see at the top of the screen, you can see the vein and the artery very clearly. You can see your needle, and then you're able to see when your needle's in the vessel. And sometimes you find that you're in the vessel, but you're not getting any blood back. And when you see that, go ahead and put the wire in. But beware of using the ultrasound alone, because if you haven't learned without the ultrasound, you might actually perk higher, because there is a vessel higher, and you can get a retroperitoneal bleed. Use the wire target technique or the vessel target technique, and this was published by Dr. Moore, where you can, if your axis, you want to get into a vessel here, for example, the IJ and the vessel's very small, you can access it from below and then put the wire where you want it and target the wire, or in this case, in the subclavian vein. Here is where you can take advantage of a peripheral IV, so you can have the nurse inject in the peripheral IV and move your needle to get exactly where you want to be, and after that you're going to be able to get your wire right in. So we now have a protocol for prevention and treatment of thrombosis. So in the past, we used to not want to know if the vessel is occluded because we didn't know what we can do about it. So we tended to say, well, if the foot is not cool, it's okay. So I'm going to go quickly through some hemostasis. So when we perforate the vessel, hopefully one side of it, we create an injury to the vessel. Platelets will go and aggregate in that region, and fibrin will come and clump the platelets together. The process will continue in the vessel, particularly if you're putting a lot of pressure on it, and it will occlude the vessel. Now, just to understand why the platelets don't aggregate initially, it's because the healthy endothelium produces prostacyclin and nitric oxide, which vasodilate the vessels and repel the platelets from the surface. We also, once the coagulation cascade has fallen through and fibrin is formed, the fibrin, this whole process is going to break down. So you have antithrombin that will stop the process or stop formation of thrombus, and then you have thrombin modulin that combines with the thrombin to block it. And then you have protein C and protein S, which also will kind of stop the coagulation process, because you only want to coagulate enough to stop the vessel from bleeding. Now, once the fibrin, that whole fibrin platelet aggregation is formed, you want to break the fibrin. So you break the fibrin by plasmin, and in order to get plasmin, plasminogen is converted to plasmin by a naturally produced TPA that the endothelium will release. So this is just kind of an overview, just a quick review. Platelets are going to be activated. Fibrin is going to come in and stick them and clump them together. Fibrin is coming from the coagulation cascade. And then you want, after you've achieved what you want the fibrin to break into fibrin degradation product, where you're going to have the TPA and your natural TPA working for you. So just to quickly go through basically the coagulation cascade, I'm not going to go through it, but you basically end up with this fibrin and the activated platelets, and that's kind of the summary of what you have. Activated platelets and fibrin, and what you want to break is you want to break the fibrin. So the patients that we deal with already have abnormal coagulation. So they have abnormal factors to start with. Coagulation proteins are increased. Their fibrinogen is increased. Their protein C and S can be decreased. Their plasminogen can be decreased. And so you can have more fibrinolysis or less fibrinolysis, and you don't know which patient you are dealing with. In addition, they can have gene mutations that make them more susceptible to thrombosis. So you have increased coagulation, increased or decreased fibrinolysis, increased or decreased platelet number and function, and plus you have damaged surface, whether it's because we poked or patient's been on ECMO or patient's been on cardiopulmonary bypass. So the common anticoagulation drugs, it's a little bit of a busy slide, and I'll just go through it quickly. We use heparin, which attacks thrombin and other factors. Low molecular weight heparin, which attacks factor 10A. Argatroban, which attacks the thrombin. And warfarin, which attacks prothrombin and other factors. And then you have the platelet inhibitors like aspirin and Plavix. And then you have TPA, which breaks the plasminogen into plasmine. And you also have AT3, which blocks the whole process of the fibrin even forming. So the ones you need to focus on here for us are the heparin, the Lovenox, the TPA, and the anti-factor, and the AT3. And you can test the levels for different ones, and for drug monitoring, I'm not going to go through all of them, just that the common ones is heparin, you check PTT, Lovenox, you check the factor 10A, warfarin, so all of that we all know. The one I want to focus on is the TPA, where the level you need to check is actually the fibrinogen level. So these are the main ones that we are interested in: heparin, TPA, integralin, aspirin and Plavix, and Lovenox as well. So the use of TPA has been what had a really bad rep. And that was early on when people were giving a bolus and using large doses for longer duration. But what was found from the preemie babies, that you only need a little bit of it. And so you can turn from a bad drug to a miracle drug. So we looked at our series, and at that time, it was only a few patients, but we extrapolated the dosing from the papers published on premature babies. So we retrospectively reviewed our patients. We had 1,500, 12 patients who developed femoral thrombosis, all received heparin for 24 hours initially. 3 did not resolve, and so we wanted to do something about it because I really never want to see leg discrepancy ever. So we gave TPA. We started with a small dose, 0.05 milligram per kilo per hour as a test dose, and then increased it to 0.1 milligram per kilo per hour for 5 hours. So the total duration is only 6 hours. And we were successful in restoring the flow, and we confirmed that by ultrasound in all 3 patients. So we got a little bit more encouraged and a little more gutsy with the TPA. We also looked at our long sheath population. Sometimes, if we're not going to go through the carotid to stent BT shunts or stent coarcs, we're going to have to use long sheaths. And as Dr. Mullins taught me, is if there's no flow around the sheath, the vessel is going to thrombose. So if you have a long sheath, there's not going to be flow around it. So we looked at our patient population that were less than 15 kilos, but particularly the long sheath patients. We had about 30 patients, and we noted that about 12 out of 29, 38% had a problem. The reason this is looking more than we are used to seeing is because we're actually looking. So we're ultrasounding these patients, and we're actually looking for it. When you compare it to use of short sheaths, when you're actually looking, you'll find that you have a higher complication or a risk of thrombosis. What we concluded from that is the patient weight was determined to be a confounding factor, with patients' weight less than 5 kilos having a significantly higher complication rate. And the odds ratio of a long sheath versus a short sheath for arterial compromise is 3.4%. So we basically said, if you're going to use a long sheath, particularly in a patient less than 5 kilos, then just go look at the vessel afterwards. We came up with a protocol, and that's for both short and long sheath, where if you access a patient less than 5 kilos, you start prophylactic heparin somewhere between 10 and 15 units per kilo per hour. You remove the dressing early so that there's not further compression on the vessel. You don't need it beyond the first hour. You check the pulses in 2 hours. You have a pulse, it's great. You don't have a pulse, then what you do is you start them on therapeutic heparin, and you keep them on that for 24 hours. You come back in the morning, they have a pulse, great. They don't have a pulse, then you're going to go looking. So you're going to ultrasound them while they're on therapeutic heparin. So if you find that there's a non-occlusive thrombus and you want your ultrasonographer to tell you if there's actually flow around the thrombus, or there's flow that's bypassed the thrombus through collaterals, because that changes your management. So if there's flow around the clot, then you know what you're going to give is going to get to the clot and break it down. In that case, you can use Lovenox. You repeat your ultrasound. If it's patent, you can stop the Lovenox. If it's not patent, you're going to continue the Lovenox for 10 days, and almost all patients will reopen if they already have some flow around the thrombus. Now, what about the completely occlusive thrombus? So that one, you check the foot. If the foot looks bad, just go straight to TPA. If the foot looks good and it's warm, you can do therapeutic heparin for another 24 hours, so a total of 48 hours. Repeat the ultrasound. If you're non-occlusive at that point, you can go to Lovenox. If you're occlusive, just go to TPA. So just to summarize the TPA dosing, what you want to do is you want to check the fibrinogen levels. So the papers that have reported intracranial hemorrhage with TPA have been in patients fibrinogen level less than 100. And if you remember that cascade, fibrinogen is how TPA, when fibrinogen is consumed, then you're in trouble. You want to decrease your therapeutic heparin to 10 units per kilo because heparin is synergistic, but the disadvantage is heparin and TPA can't run in the same line, so you have to have a separate line. You're going to use that test dose, 0.05 milligram per kilo per hour, and that allows you to use it. We've actually used it in patients post-operatively because it gives you, you can just feel the waters with the test dose. Then go to 0.1 milligram per kilo per hour, and it's only 5 hours. You just shut it off after 5 hours. And then you go back to your heparin at therapeutic when you stop the TPA. You can repeat that in 18 to 24 hours, so long as your fibrinogen is more than 150. So once it drops below 150, then forget about the TPA. But it's actually infrequent that the fibrinogen will drop with that short burst. In conclusion, prevention of thrombosis is the best treatment. Refined techniques for access is key. Use of ultrasound is good, but you have to know your landmarks and actually learn the old-fashioned way first. Small size sheaths are very helpful. Don't be afraid to find out there's a thrombus, so go looking for it, but initiate therapy early. And the use of TPA in small dose for short bursts is effective with less complications. Thank you.